Step 6 in our pre-bypass mitral valve evaluation will consist in looking at all the other cardiac data that could be relevant for the surgery. Looking at LV size and systolic function, LV size can dilate over time with chronic mitral regurgitation and volume overload. The function can appear normal, but because there's significant regurgitant volume in an MR jet, normal LV ejection fraction does not always indicate normal cardiac output. Lastly, in regards to LV, you'll want to get a baseline regional wall motion assessment. One of the main complications of the surgery can be injury to the left circumflex artery, which can cause regional wall motion abnormalities. So knowing what is normal beforehand can aid you when you come off cardiopulmonary bypass after the valve has been replaced. We'll also assess the left atrium and left atrial appendage. We would expect the left atrium to be dilated in chronic mitral regurgitation and chronic mitral stenosis patients. And this makes patients prone to atrial fibrillation as well, which is why we'll also want to check the left atrial appendage for thrombus. We'll look at RV size and systolic function, and also pulmonary hypertension as well. These patients have pulmonary hypertension because of the increased left atrial pressures causes this WHO group 2 pulmonary hypertension from left-sided heart disease that causes back pressure through the lungs and on the right side of the heart system. So this increased pressure on the RV and the RA cause dilation and dysfunction, which can also lead to functional tricuspid regurgitation as well. We'll assess our aortic valve pre-bypass in these cases because the aortic valve is at risk of injury because of its close proximity to the anterior mitral valve leaflet. Remember as well in mitral stenosis patients that bad aortic stenosis can lower the flow artificially across a mitral valve because of low flow states. Also, if there's severe mitral stenosis and there's a low flow state from that, it can artificially lower the gradient across the aortic valve. So these two can affect each other when there's significant severity from one interacting with the other. Also, significant aortic insufficiency can make pressure half-time measurements invalid. Lastly, when looking at other cardiac data, we'll assess the tricuspid valve as well. Moderate TR without a dilated annulus, which would be less than 4 centimeters, often improves after mitral valve surgery. However, if there's progressive TR with either tricuspid annular dilation over 4 centimeters or prior right-sided heart failure symptoms, that's a Class 2A recommendation for tricuspid valve intervention at the time of mitral valve surgery.